Good afternoon, everyone, and welcome. We're really excited to have you all here today. It is our first of 3 webinar series titled Homeless in the ED, Partnerships to Improve Care for People Without Homes in Emergency Departments. My name is Courtney Pladson. I am the Director of Clinical and Quality Improvement here at the National Healthcare for the Homeless Council. I'm incredibly excited about this webinar series and today in particular, where we're really going to be focusing on homelessness within the emergency department. I am really excited for our speakers today, Dr. David Munson and Dr. Enrique Nguyendanos, who I'm going to introduce, but just wanted to share that one of the reasons why this was so important for us and why we wanted to do this series in the first place is that people experiencing homelessness disproportionately utilize the emergency departments. And we have these 2 groups, folks that work within the ER and folks within our healthcare for the homeless community that are all caring for this population, but often aren't working together or coordinating care. So we're really wanting to explore how to better partner, how to best utilize resources of both to better care for folks experiencing homelessness. I started off my career, I worked 7 years in the emergency department, and when I was in the ER, I had no idea that the healthcare for the homeless clinic was right down the street. And so coming from my own naivety at that time, it just to me is so important for helping staff in the ED know about the immense amount of wealth and resources within the healthcare for the homeless community. So we're really excited to start this conversation. I just want to acknowledge that this presentation is supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services as part of an award. This is all financed with non-governmental sources. The contents of those of the authors and do not necessarily represent the official view nor an endorsement by HRSA, HHS, or the U.S. government. For more information, you can go onto HRSA's website. And just a disclaimer, the contents and opinions expressed in this presentation are solely of the presenter, not necessarily those of the National Healthcare for the Homeless Council. At the end of our webinar today, we're going to share a survey, and we really love your input. As the first of 3 in this series, we are continually in a space of improvement, and we want to make sure that these series are impactful and are really meeting your needs and going to impact your community. So we welcome all ideas, suggestions, feedback. We'd really love for you to be honest so we can continue to make our work better. And on to the good stuff. So I'm really honored today to be joined by Dr. Enrique Nguyendanos, an emergency room physician and the CEO of Community-Based Coordination Solutions out of Seattle, Washington, and Dr. David Munson, Medical Director of the Boston Healthcare for the Homeless program. And I am going to turn it over to the 2 of you. And then I'll join back at the end for lots of questions. So throughout the presentation today, we'd love for you all to put your questions in the chat so we can at the end have a discussion and answer your questions. So I'll turn it over to you both. Thank you so much.
Thanks a lot, Courtney. I appreciate that. I'm Dr. Enrique Nguyendanos. So we can go to the next slide already. We're going to do a quick introduction. And I really just to start want to parlay on what you said, Courtney. I really appreciate the efforts that the council and that ACIP are doing to work together and really call this issue out to attention and try not to continue the silo of care that we see so often in various parts of medicine. I'm an emergency physician based in Seattle. Some of this comes from 20 years of working ED director in a 100,000 visit shop, and those experiences I'm involved with our national organization, the American College of Emergency Physicians, and their social section and their EM practice committee. But a lot of this experience also comes from my work with community-based coordination solutions, where we're going out in communities around the country, setting up high navigation programs for individuals struggling with homelessness and substance abuse and mental health. So working hand in hand with that cohort. And I've been blessed to work on a couple of projects now with Dave. So Dave, I'm going to hand the baton off to you.
Thanks, Enrique. And just really happy to be with you all this afternoon. I'm an internist by training and have worked with Boston Healthcare for the Homeless program for about the past 10 years in a couple of different roles with our group in both street medicine and in our medical respite program, and have some experience on the national level with medical respite as well. And we'll talk a little bit kind of at the end about one of the roles that respite can play in helping to to work with the emergency departments. But I'm also really excited to be part of this, and just to underscore what Courtney mentioned about really trying to improve the partnerships between the ED side and the outpatient homelessness services side. So we can go to the next slide. Courtney, please. Great. So, just a quick agenda to sort of tell you guys what we're going to tell you about today. We're going to talk a little bit why this is important, why this topic's important, share some data about emergency departments and homelessness. We'll talk about kind of, some general demographics and utilization and epidemiology of homelessness, mostly as a level set, as this is the beginning of this series of lectures, so that everybody's on the same page about the populations that we're taking care of. We'll talk about experiences and stigma really is important to sort of understand and dig into a little bit. And then hopefully leave you guys with some tools and some opportunities about ways that you can, in the short term, that don't require too much of a heavy lift, think about how you can change your practice a little bit going forward. So the next slide, and I think Enrique.
Yeah, so I think one of the things we're going to talk about data here shortly, but there's a dearth of data, frankly, around homelessness. I'll quote the numbers here shortly, but I think any of us working in the FQHC and the ED in the primary care environment will recognize that some of this will be experiential. But, why this topic? I think emergency departments arguably offer more homeless care than any other specialty in medicine. And what's true is that we as emergency physicians receive very little specialized training in how to care for the homeless. I think that's starting to change. I think we're starting to call that out. And I really want to call out the council and ASIP for recognizing that and leading that charge. But I don't think there's any question that our homeless population carries unique risk. And when we have the current silo of care, the differences between ED care and primary care and street care, gaps exist, and those that suffer most end up being our patients that are bouncing between silos. Next slide, please. So here's some data around ED utilization. Well, we know there's more than about 500,000 folks living out on the street on any given night. And amazingly to me, is that almost half of these are single women, and over a third are families living in homelessness every night. The median age is increasing now above 50. One thing we'll talk about later as we talk about action items is how to identify our homeless. When we look at data, and most of this is diagnosis data, the data shows about 0.5% of ED visits involve a homeless individual. And any one of us that have worked in any ED in the country know that it's much larger of an incidence than that. On any given day, I would offer that 20% of my clients are likely homeless. But the issue is underreported, and there are things we can do with that to improve that and be able to recognize the issue better. We do know that a homeless individual, as Courtney referenced earlier, will visit more often, and the data shows about 3 times higher than the general population. And there is high morbidity and mortality associated with our cohort. Recent data will show that 30-day discharge from the emergency department, a homeless individual will have about 30% more ED returns and about a higher rate of admission. Next slide, please.
Great. So we'll just spend a few slides diving into a little bit of epidemiology and disease prevalence of homeless folks. This is an example. Enrique mentioned the how many homeless people exist on any given night. And one thing that is just always kind of neat to know about is that most every city in the country does a one-time homelessness count every year. In Boston, this happened just a couple of weeks ago at the end of February, where the folks go out on the street and count up people who are outside, count up people who are in shelters, count up people that are in hospital, to get a sense of how many people are outside on any given night. And those generally happen at the end of February. This is the data from Boston, just to sort of get a snapshot of how it's broken down. This is obviously the past couple of years really impacted by the pandemic. We could have a whole set of conversations about how the pandemic has really disrupted a lot of the infrastructure in some positive ways, actually, around homelessness and shelters for sure, and led to a lot of associated morbidity in a negative sense. The next slide, please. This is an old slide of mine, but I think it's still really relevant and interesting, especially for y'all in the emergency room, just to underscore that most people experiencing homelessness in the country have an unmet healthcare need. And this, of course, will vary a little bit from state to state, especially in states that have broader access to care like Massachusetts versus states that say haven't expanded the Affordable Care Act. But most people have an unmet healthcare need. And why that's relevant for y'all, especially in the emergency department field, is that people don't always have access to care on a regular basis. They don't always have access to primary care, preventative care, and that's gonna sort of roll downhill to you guys in the emergency department. But there's a lot of unmet needs, from medical to prescription to mental health care to dental care is just really, really needed. So there's a lot of unmet needs out there on the primary preventative side. The next slide, please. And we can just forward one more time, Courtney, please, in here. Great, thanks. So the next two slides are a snapshot from some BHCHP patients, so patients that Boston Health Care for the Homeless program has followed longitudinally for many years, basically to just convince you and show you that our patients, and when I say our patients, we're really talking about folks that have been chronically homeless for the most part. So many episodes of homelessness over time, or homeless for a long period of time, are sick. They carry a number of really complicated chronic medical conditions. 6 or 8% with HIV, a number of folks with chronic liver disease, chronic lung disease. And again, I think it's important to try to imagine managing these conditions in the context of homelessness. For example, if you're an insulin-dependent diabetic, and you don't have access to a regular access to a diet that you can control, you might be in a situation where your sugars are consistently out of whack. Or if you're someone that struggles to store or maintain insulin or insulin injections, then you may be someone that's going to present to the emergency department in DKA frequently because you're not able to access the infrastructure that's able to keep your medical conditions under control. So our folks tend to be complicated medically. There tend to be a lot of complex medical conditions, and you guys are seeing this in the frequent admissions that you sometimes see in the emergency department. We can go to the next slide. And we can just click through 2 times, I think, please. One more time, actually. Great, please. Thank you. So this is the same cohort of patients, just showing that there's a lot of complex psychiatric illness and substance use that's going on concurrently with these folks. So, in this cohort, this is data is chart based. So again, probably an underscore, we have about 20% of our patients with schizophrenia coded as a diagnosis. 60, but probably upwards of 80% of patients have a substance use disorder. Certainly if you were to include tobacco in that, it would be quite high. And then a really striking number of patients that have both a complex mental illness and a severe substance use disorder. And many of the folks that we see, and that I think you see, really have one from the previous slide. So say cirrhosis and alcohol use disorder and bipolar disorder or something like that. So really a complex mixture of both medical and psychiatric and substance use disorders that lead to sort of a complex presentation in folks. And I imagine this resonates with the folks on the call in terms of people that they're seeing every day. We can go to the next slide. And it shows up in mortality, and the data around mortality is really striking in people that experience chronic homelessness. This is a study looking at BHCHP patients from the early 2000s, and it mostly holds now. And it really shows you that the number one cause of death, if you're a chronically homeless person in Boston, is drug overdose. If you're a young person, 25 to 45 or so, drug overdose is the number one cause of mortality for those folks. And that rate of death is 9 times that of the non-homeless matched cohort of folks. So pretty striking increased rate of mortality. And then interestingly, in the second group, it's these chronic diseases that are killing people. So what we see in our folks is we see head and neck cancer that's presenting, advanced head and neck cancer that presents at 48 years old or something like that, or someone who has diabetes who's presenting with end stage renal disease in their early 50s or something like that. So these are the end stages of chronic disease that get pushed up sooner. And then cancer and chronic heart disease, chronic medical conditions are the causes of mortality for older folks. And we can go to the next slide, which really just and then click one more time, please. And we're seeing one of the things the pandemic has done is it has displaced a lot of people from shelter. We've closed shelters, we've thinned out shelters, we've put more people on the street, not intentionally, but that's definitely has happened, that there have been more unsheltered homeless folks. This is some data that sort of tries to convince you that, and does show you that folks who are unsheltered as compared to sheltered homeless adults have an even higher rate of mortality compared to sheltered folks versus compared to the non-homeless population at large. And this generally is because folks have more of that combination of chronic medical conditions, chronic substance use disorder, and chronic mental illness. So just to sort of convince you and show you that this is a really complex, vulnerable group of patients that you're seeing. And I think you know this, but I think it's always helpful to see the data. And we'll look at one more slide on the next slide, please, Courtney. And this is just to really underscore that, especially in the last, 5 to 10 to 8 years, drug overdose is really driving a lot of this mortality. And if there's one thing that you take away from this, and you probably knew this coming in, but if you didn't, just understand the overdose risk for someone experiencing homelessness who at any given time is really quite high. And this is the Massachusetts data. Could be it's a representative sample for national data. It's more striking for Black and Hispanic folks experiencing homelessness. There's clear racial disparities in this, that the overdose crisis is really striking for folks experiencing homelessness. So understand that risk of someone with an opioid use disorder and homelessness who's going to be in your emergency department. And I think that's the last slide I have. Oh no, one more slide about respite, sorry. I forget respite. So just as sort of and I think there's a whole webinar about respite, the third one, but I did think it would be important to just mention respite as a way to really link in with the emergency department. So medical respite is this kind of funky service model where for folks who are too sick for the street or the shelter, but not sick enough to need to be admitted to a hospital. And there's about 75 or so medical respite programs across the country. They all look a little bit different. And again, I think there's going to be a whole webinar about this, but there's some great data for respite showing that it decreases hospitalizations, it'll decrease readmissions. And one of the more interesting things about respite is how, and you guys are seeing patients who are living in such chaos all the time, sometimes on the street or in shelter. And one of the things that respite can sometimes do is really stabilize folks. So get them connected to benefits, maybe get them connected to insurance, maybe get them some identification that they don't have, maybe even connect them into housing as a platform that they're just not able to do from the street or the shelter. So we can talk more about respite later on, but it's important to sort of understand that as a tool to help out with folks experiencing homelessness and ED. I'm going to pass it to Enrique for the next couple of slides.
Thanks, Dave. Next slide, please, Courtney. And I really want to call out the organizations like Boston Healthcare for the Homeless, the work being done in pockets of the country like New York and LA and Seattle to collect data. But at the end of the day, there is not a lot of data around homelessness, at least not as much as for other medical conditions, partly because we're not calling it out on our diagnoses as much as we can. And a lot of the data that's being collected is retrospective data based on diagnoses. And then it can take a while. I mean, these are silos. We want to move quickly. We need to move quickly in our country. And in some instances, we don't want to wait around for the data to drive the dialogue. And so we can't ignore the experiences. We have to take every experience with a grain of salt and recognize it's one story. But I think it's something we do have to listen to if we're going to act quickly. And yet, as any good leader, any good manager would recognize, when we're talking about stories, experiences, we have to listen to all sides. of the story to get a good sense of what's going on. So over the last few months, Dave and I have been listening to stories from ED providers, from outpatient providers, from patients, and we want to share the general themes of what we're hearing. So there's a feeling, at least amongst ED providers, that we are the de facto primary care for a lot of our homeless that are not going elsewhere for their care. Issues evolve to a crisis point and they come to see us. And we ED providers may be the only physician that many are seeing. And while we have expertise in the area of emergency medicine, we aren't generally the pace and we're not generally trained for chronic care. And we've repeatedly told folks that, and yet the system hasn't changed. That's our frustration as ED providers. And finally, probably most importantly, we don't have in most communities, good real-time referral sources. And when I say real-time, 8 hours of the day, we'll be seeing folks where there may be some resources, but another 16 hours and weekends, we may be the only resource available to them. And we're repeatedly seeing them for issues that no one else is helping with. Now, that's the perspective of most of the ED providers we've talked to. Next slide, please. As we listen to our outpatient providers, it's interesting because there's often a feeling that the ED isn't addressing the underlying issues. And what I've found surprising, but I totally get it when I look at the perspective of outpatient providers. The emergency department has more time to deal with things than we do. And yeah, a patient may be in our ED for a few hours and may only have 20 or 30 minutes in a clinic. But that's an interesting perspective, I thought. The final comment is the one that really bothers me as an ED provider, and I think is very legit, is that if we in the emergency department don't connect well with our homeless, we may lose them forever to healthcare. If they have a negative experience, we may be the site of last resort. And so we really need to make sure that the experience is a good one. Otherwise, they may shy from the healthcare system completely. Next slide, please. This is probably the most important slide, is hearing the experience of our patients. And this is just a summary of feedback we've gotten from clients, from patients, from individuals. But I really think it puts things into good perspective. This is a client we saw just a couple of months ago that had been very aggressive in the ED with us. Actually came in swinging, not necessarily swinging at us, but yelling obscenities. And I was amazed at how our RN staff just stayed level-headed, engaged with him. He had been using meth, and slowly kind of chipped away at the veneer. And at the end of the 3-hour stay, the individual asked us to come in the room and pray with him for a good outcome. And then sat down and told us, look, I'm sorry I'm mean, but I got to be mean to be able to survive on the streets. That's just my MO. I got to do it. And it was really just a testament to our nursing staff that was so steady and compassionate with him throughout. I generally don't like to read all my slides, but these stories are so important. I'm going to read each of them. If it weren't for the emergency department letting me sleep here last night, I would have died out in the cold. And that's a verbatim quote from a client from a couple of months ago. When the doc listens, instead of talking right away, it makes me feel heard. This one I felt particularly heartwarming. I know I always have the ER. Sometimes there's just nowhere else I can go. I feel validated as a person just by the fact someone's listening to me. And the last one is one that I really struggle with. I feel judged as a bad person just because I'm homeless. And I know I have acted in a way that stimulates that response over the years. I have to constantly catch myself, but I do think it speaks to the issue of stigma. And Courtney, if you could move on to the next slide. Dave and I wanted to call out the issue of stigma because it's a door check that we have to do. I have to do every single time before I go in to see someone, because it's so easy for me to rely on my experience, whatever that may have been each time. And frankly, that's a great tool for us to have. But each and every individual is their own story, and they bring in their own baggage that we don't know. And it can be tough for us in the ED, particularly if we don't know an individual, to handle the swinging and the issues that the nursing staff did so wonderfully with that last quote I mentioned. But when we come in with a negative label and we know stigmas are an issue, the individual is eventually going to be reluctant to come for us for help, and they themselves will start believing in the stigma and recognizing or feeling as if the healthcare system isn't going to be helping them, that we're almost working against them. And I think the onus is on us to really go the extra yard to break out of these stigmas. Next slide, please. There is some data coming out on stigmas, and this is, many of you probably read this JAMA report from earlier this year. The majority of homeless folks seeking drug treatment felt stigmatized. Now, granted, the thought is that those experiences are improving, and we, my ED cohorts and I, are getting better at that. But interesting, the same cohort felt that the majority of patients felt that ED providers weren't well versed on starting opioid treatment, and that's something that shouldn't be the case anymore. We have buprenorphine. Every ED in the country, every ED provider should recognize how to use that. We should recognize where our opioid bridge programs are in the community, who our outpatient treatment providers are, and we'll talk a little bit about action items coming up. There was a strong feeling that the paper list of resources we give wasn't adequate, that I give still in my ED. So I've tried to go the extra mile and call those individuals on the list, those resources on the list, find out which ones are Spanish speaking, find out which ones are actually accepting Medicaid, find out which ones have an active opioid program. So I think we can do better at finding out what resources we're handing and engaging the resources in our community. And then data that people experiencing homelessness or people experiencing incarceration with COVID-19 had more frequent admissions, longer lengths of stay, higher mortality. I think there's a lot more work we need to do to recognize stigmas, to improve our behavior around stigmas. Next slide, please. I want to call out the American College of Emergency Physicians. Dr. Stater and Dr. Anderson did a wonderful video. It's about a 10-minute video. I've placed the link here. And it's offering some insight from patients, from our providers, on stigmas related to opioid use disorder and how we can do better. And then I want to invite you also all to a podcast that specifically addresses stigma in healthcare that I've provided a link for each of these here. Next slide, please. I appreciate all the questions that are coming in. Typically, Dave and I would love the questions to answer them as we go, but we've been asked to field them all at the end, so please keep them coming and we will get to them. I think that's the more important part of all of this. But before we get to the Q&A portion, we felt it's important to call out a few things that we felt could be done today to make a difference. And I think all of us, frankly, in the emergency department or in the outpatient setting, probably the first and foremost thing we can do is express a sense of caring. And I think it's simple things, just making eye contact and listening, shutting up, frankly, and listening to each individual story. And maybe it's going to be a minute, maybe it's going to be 5 minutes, but there'll be 5 minutes well spent. It's quotes from some of our providers in street medicine that we've talked to over the few months. Active listening is going to be the best 5 minutes we can provide. And take the time for the small talk and check up on folks when you see them the next time. Validate their humanity. Make sure we identify what their concern is, which may be very simple and may be completely unrelated to the medical issues we see and we know they need attention for, but identify their concern and address it. Be cognizant of the stigmatization. And for myself, it's just taking a moment, 5 seconds to take a deep breath before I walk in and make sure I focus on not passing judgment and not preempting things, to listening to their story. And then we've called out the fact that we in the emergency department don't often call out homelessness as a diagnosis code. We need to do that as an additional code, because a lot of the data we're going to be using to drive dialogue, to collect, is going to be based on diagnosis coding to identify a homeless situation in hindsight. So we can do a better job. There are ICD codes around homelessness. By just calling that out, even if it's the third or fourth or 10th diagnosis we put on our diagnosis list. Next slide, please. Dave, I think I passed this one on to you a little bit.
Yeah, I'm going to do this one. And these are great questions and comments. I'll just echo that. So looking forward to, we'll finish up in a few minutes here and then we can have a great discussion. I think these are some ideas about things that we, thought for encounters that happen in the emergency room to think about. And obviously the acute issues that bring someone in are going to take priority, but there's some other things that you could think about as ways to engage with people, with folks that are coming in frequently. I will just echo what Enrique said in kind of the middle lower bullet there about opioid use disorder really as being a #1 driver of mortality these days for folks experiencing homelessness. Thinking about getting X-waivered or understanding where in your community the bridge Suboxone programs exist, and working with community-based providers to establish or further establish some sort of referral process for folks to get onto Suboxone is a great thing, to sort of tangible, practical thing to work on. And some places it's easier to do than others. I can tell you in our world, that's a lot of low threshold prescribing of folks, a lot of short prescriptions, a lot of trying to, see people the next day or see people the same day. We've tried to put we have a clinic, one of our clinics in the hospital. So we're able to sort of see people on the same day or try to do a warm pass off for folks. Obviously, trying to engage people around smoking, thinking about some chronic disease management stuff. Again, this is outside the bounds of what's usually thought of as emergency department care, for sure, acknowledging that. But, these are things that folks, are in need of. And obviously to help getting a PCP. So understanding, who are the providers in your communities who take care of folks experiencing homelessness. They're probably around, and it's, I would say it's probably worth a little bit of time in terms of an investment in terms of figuring out who those people are, making some connections, setting up a phone call or a Zoom, or having a quick meeting, a cup of coffee, just to understand that, and then work on referral sources from there, so that hopefully folks who are coming back frequently for what are generally thought of as outpatient or primary care things can get plugged into the sort of the more appropriate type of care. We'll go to the next slide.
And I want to follow up on that, Dave, because I think
Yeah.
as we go, no, you go ahead and go on to the next slide, Courtney. Three things will happen as we do this better. One, the patient will get better care. Two, I guarantee you, the emergency department is going to flow quicker. A little investment up front on recognizing the resources that are out there is really going to help you at the crisis time in the ED. And I've seen it time and time again over my 25 years in clinical emergency medicine. And probably the most important thing to help us with burnout is we as providers are going to feel so good one time making a difference, once a month, once every 4 or 5 months, connecting someone with the right resource. You will remember that. It will empower you as a clinician during those tough, long days in the emergency department. I tell you from experience, it makes a difference. And so we want to provide some action steps that can be done within the next month, easy to do in the next month. I talked about how I'm going around the country setting up high utilization programs. We lean on our health information exchanges and community information exchanges tremendously. If you're blessed enough to have an organization like a Collective Medical or a Script statewide program in Maryland or some type of statewide HIE where you can share care plans, where you can share visit information, understand how to learn that, because it's a lifesaver for you practicing, but a lifesaver for the client to have that information readily available to you and know how to manage that. And arguably more importantly, the community information exchanges, which are free to us, the Aunt Berthas of the world, the Unite Us of the world, the findhelp.org, that tell you in real time where the shelters are, where the behavioral health centers are, where the opioid use disorder, the opioid bridge program in your community, where the clinics are. There is a dearth of, or there is a large amount of information available, and I really would call out those two organizations, Aunt Bertha and Unite Us. Those are tools we can access in real time in our emergency department that will allow real-time connections with phone numbers that we can refer people to 24/7. We as ED providers need to understand how to use buprenorphine, and we need to know where the programs are for us to refer folks to. There is no reason in March of 2022 that we should not be doing that with each of our individuals presenting with opioid use disorder. And we should be making sure we need to know they have access to Narcan, to naloxone. So this is something that I think we have no excuse for. I appreciate the efforts that our college has done to set up programs, but we need to be able to act on these today. I would invite everyone to find out who their street medicine team is and just shadow them for a day. Understand what they're doing, understand how they're meeting people. It will be a life changer for you to just spend 4 hours shadowing your street medicine team. Join the council. There is quite a bit of information. In fact, we'll share some. And make sure you talk to your local FQHCs. Have a cup of coffee, like Dave said. Find out, do they have slots from 7 to 8 a.m. that are open? That if you have someone at 3 or 4 in the morning that needs a follow-up instead of an admission, you might be able to send them there quickly. And understand the medical respite programs in your community, the shelter programs, develop relationships with them, find out how you can refer clients to them, what their restrictions may be. These are all things that we can do within the next month that will absolutely make a difference in our practice and make a difference for our patients. Next slide, please. We want to call out the work the council has done. This is a link to a set of clinical guidelines that were created in 2018 by the council. Some of them are really simple, but it's worth spending an hour looking at all of these and just stimulating some thought process. Some of this, 80% of this stuff we're doing already, but they're going to be 20% of nuggets that will really help us think about how to approach treatment for each of these. with our homeless population. Next slide, please. And then what's coming down, long term, I'm really encouraged. Part of it's through this webinar series, but the collaboration that's evolving between the National Healthcare for the Homeless Council and the Council and the American College of Emergency Physician, their dialogues around improving homelessness training, their dialogues around improving medical assisted treatment connections, around joint advocacy. And I want to call out all of us in our individual communities to consider advocacy with your legislative bodies around increasing shelter capacity, around improving behavioral health facilities, around opioid bridge programs. Stories are so powerful, and we have to consider that for this patient population, for our homeless, we are going to be their voice in advocacy, and no one knows the stories as well as we do. So think about the power of those stories and what you can do with them. Next slide, please. I think we've hit the Q&A session, Dave.
We made it.
Hopefully that was helpful.
Thank you both so much. That was incredibly helpful and such a fantastic foundation for this series. And as you saw in the chat, there are lots of questions and lots of wonderful positive affirmations, and thanking you both for this topic. A few things that I wanted to highlight, and folks feel free to add more questions to the chat. I'm going to raise those, those are the questions you already shared. I think one thing that I was really interested in, you both really touched on this number of times, is really that we're still at the height of an overdose crisis. We're coming off of another record year. And this, to me, with overdose being one of the main drivers of mortality for this population, it is one of the, to me, most impactful ways that we can really work on this partnership together between ERs and healthcare for the homeless community. One of the questions Jonathan had that I thought was really important, and I hear this a lot from the HCH side, is how can we communicate the resources we have to the emergency departments? We work so hard in our field in healthcare for the homeless of decreasing barriers, having walk-in access to buprenorphine, but maybe the ER might not know. So one of the questions Jonathan had was, with the turnover in the emergency department, how do we share the wealth of knowledge that is in our community and let the ER know how to best utilize these resources?
Yeah, I'll start on that one, Dave, if you want. And I think there's a couple of answers to that. That there's the buprenorphine training up front, understanding how an ED provider should recognize who needs immediate treatment and how to start that treatment. But that treatment is not effective, or not greatly effective, if we don't do the follow-up step of connecting with the outpatient provider. And I've been in countless communities where the resources are there out in the community. In fact, I'll talk to state agencies, to insurance companies that say, we have 30 providers in that community that are looking for opioid patients, and the ERs aren't sending them. It's because the ERs don't know where to send them, the EDs. And so to fill that gap, there are things we can do as ED providers. I called out the community information exchanges. And I'll mention them by name again: Unite Us and findhelp.org. Those are both free tools that we can click on 24/7, put in our zip code, and they will identify most of the MAT, the opioid bridge programs in our community. So that's a very simple step to do in real time during your next shift tomorrow or later on today in the emergency department. The other is there are more and more tools. SAMHSA, if you go on their website, can call out some of the opioid treatment programs in different communities through zip codes. Some of it is elbow grease, and I'd recommend identifying your FQHCs in the community, starting there, and they will likely have names and numbers that you can easily refer folks to. Dave, I don't know if you'd want to add on to that at all.
Yeah, that's great. I think from sort of from the other side, from the healthcare for the homeless provider side, I think it is a good point that there can be a lot of turnover sometimes. The shift work of emergency department medicine, I think, is a little bit tricky from the outpatient side in terms of knowing who to talk to and who to convey resources to. So to acknowledge that point, I think what I've found helpful is to identify a few champions in the emergency department, and then communicate, what information. So you identify, so the hours of your clinic, for example, on the outpatient side, or the number to call, and you communicate that to the champions in the ED, and you ask them to then sort of bring that forward across however information is shared in the emergency department, and then you keep at it. Yeah. And then you go back in 3 months, and you go back in 3 more months, and you talk to the house staff if there's house staff, and you do a little spiel for the house staff, to sort of build up the connections. And it takes a lot of work initially, to sort of build that up and make sure people understand what the follow-up needs to be and where the numbers are. But there tend to be some good returns from that. And the other thing I'll say is that and I think, Courtney, you mentioned this, but there's a lot of overlap between the substance use disorder work and the homelessness work. So what has helped in our collaboration with MGH is that MGH has embedded a couple of like substance use disorder specific nurse practitioners in the emergency department, and they do consults in the ED for substance use disorders. Now they're probably seeing 80% of the homeless people in the emergency department, just because that's who's in the emergency department, who's homeless. And so we have a great relationship with them. And so they reach out to us on almost a real-time basis. If we know somebody's going to be in the ED, we reach out to them on a real-time basis. And there's a lot of collaboration that can happen because of those individual relationships. So there's the individual relationships with like specific people, and then there's like getting champions who can then disseminate the info across the ED, because it's hard in a huge ED. Like Enrique, your ED probably has 200 staff or something like that, right? Yeah, so it's hard to like, how do you get all the information out so that it's at 6 o'clock in the morning on a Tuesday, somebody knows what to do, right? So,
and I would tailor on the champion issue you called out, Dave. Stories. So when we think about champions, if you're blessed enough to have a patient that has gone through and is willing to come back and tell their story, the power of that in your community and to your providers and staff is going to be so effective.
One thing I wanted to add is learners. I have had emergency room physician residents come through in our partnership with Maine Medical Center. Their ER docs come and rotate through our Healthcare for the Homeless program. And that has really helped to solidify that partnership and that relationship as well.
I mean, Enrique, you mentioned like the shadowing of the street medicine. I mean, it's that, like, underscore that point. Like it just opens up a whole set of opportunities and ideas.
It's so, this may be unrelated, but one of the best things I ever did in my life is have my wife shadow me in the ED for a day. During my internship, and it changed our life radically. She has no medical background, and yet she could relate suddenly. And I think a similar analogy applies here is for us, just 4 hours on the street is going to change our perspective and broaden it so radically that it'll be real powerful.
And I should just highlight all learners, not just physicians, but nurse practitioners, nurses, social workers.
Absolutely, anybody.
At all levels. Mm-hmm.
Yeah.
Some other questions that folks shared. So I had a few questions around documenting homeless status. And I know you discussed, Enrique, adding the ICD-10 code. But one thing that someone highlighted that I thought was really interesting is the documentation is one, but how do we prevent adding to the stigma? I see this a lot in documentation of ER notes of, frequent flyer, homeless, a lot of the stigma that gets piled on. So how do we document the need so we can demonstrate the need, while also trying to not add on to stigma for when clients are presenting? So just curious your thoughts about how we weave that.
I tend to jump in first, Dave. So I got a thought, but I don't know if you want to.
No, go for it.
Courtney, this may sound dumb and stupid, but the first thing, and probably the most powerful, I think, is just read my old frickin' note before I sign it. So I have to, I'll write as I go. I tend to write my notes while I'm seeing patients, but I just need to check myself. And particularly now, within the last 2 months, patients in my organization can see their notes in real time. And I've gotten called a couple of times before the patients even left and asked in a nice way by a patient, this isn't my interpretation of what happened. Can you clarify your note for me? And I think that's great. And I think I have to look back and read what I've put down. And I'll find frequently that, you know what, that shouldn't be how I'm explaining the story. That's not really, it doesn't read, or sometimes there was a dictation transcription error that happened. But most of the time, it's just me being more careful about how I'm wording my story to, frankly, catch my own pattern of stigma and improve on it.
Yeah, I think the data collection is really, really important, and it's different. And I think the chart diagnoses, the use of the Z59 code, is different than the syntax that you use when you're describing in a note. So calling out that difference, and I think just being aware that there's a lot of stigma around people experiencing homelessness is into itself. If you're aware that your interaction with someone you may be carrying an unconscious bias or conscious bias into those interactions, I think can go a long way to minimizing that. If you can kind of, and then obviously just, the copy, we copy forward so many of our notes now, which is dangerous. So just being mindful of the things that you're copying forward in the text. But I would really emphasize the need to use that Z59 code as much as we can, just so that we can get better data. Michael's probably making a point about the council here. Oh, that's good. Yeah, that's good.
Can I add one more thing to that, Courtney?
Yeah.
The other thing I called it out in the presentation was asking the patient. Most of the time, I just have to sit back and listen. What's your perception of stigmas? Are you experiencing stigmas? How can I, as a provider, help improve on that, address that? And they may have an eye-opening answer that may change, and that's happened. That it changes how I approach and how I document and how I tell their story.
That's really helpful. Thank you both. One of the things that is interesting hearing and thinking about the stigma and thinking about how we make these connections, there are staff meetings, there are ongoing trainings like within the department. So I'm wondering how, as you mentioned, Enrique, so many folks working within the ER have never had specific training on working with people experiencing homelessness, trauma-informed care, harm reduction. So how do we leverage the expertise of our healthcare for the homeless partners, bringing them in to do our lectures, to come in and talk about some of the specific resources and skill sets, and trying to help actually squarely combat that stigma. So I think kind of dual strategies is really building that connection, and then how do we leverage the expertise of our healthcare for the homeless clinicians and doing some of those trainings as well, I think could be really powerful. One of the things I wanted to ask about, or Ian asked this, is many cities are trying to work collaboratively to address chronic homelessness and decrease homelessness. And Ian asked, what could the role of the emergency department be in eliminating homelessness? How could they participate in this community-wide effort at decreasing homelessness? I thought that was interesting. I'm open to thoughts on that.
Yeah, I first of all think in answering that have to acknowledge the health institutions that have begun donating money and donating advocacy to the topic. The Kaisers, the United Healthcares, and others, but those are just two that come to mind. I don't think we'll solve it. I mean, I think we can help, and there are a lot of steps that we'll take to help. I think simple things like recognizing our community resources, and I refer back to those community information exchanges, recognizing how to use the tools like Dave's Respite program and other Respite programs we have. I think working with our FQHCs to address the chronic conditions that may lead to homelessness and try to mitigate those as much as we can. Dave?
Yeah, I think it's a great question there's no great answer to it, I don't think. I think the focus on trying to I think we've talked a lot about there's two parallel care streams here, and trying to bring people together as much as possible. So being aware of the resources and really building strong linkages between the emergency department and the community-based care providers, I think, is probably the best like most practical thing that can happen there, because that way when someone is discharged from the has a planned discharge from the ED, they can have a planned discharge to land someplace with care providers who know them, with folks who can, maybe they're getting into shelter, or maybe they don't want to go to shelter and they're going to be outside. And there's care providers that can take care of them outside and move things along in that way to sort of move them out of homelessness. But I think when the EDs are not aware of the resources that exist in the community, then folks are just going to return to the street with nothing, because they're not even aware that resources might exist.
And Courtney, I think there's one more thing. I referenced this at the end of the presentation. The stories are so powerful, and the onus really, to some extent, falls on us. We are the voice. We will be the voice. It's a complex issue, and no one really understands the entirety of the complexity. But those of us working in FQHCs and in Respite and EDs can be the voice and tell that story at an advocacy level and really drive some of that difference.
I really love that perspective, and that's such an important piece of that. For good and for bad, clinicians are listened to when we go to state advocacies and we go to our city councils. Those stories are really powerful, but use those letters after your name to advocate for system level change. And because I don't want people from the ED to think we're leaving this conversation saying it's all in the emergency department, because it's not. The ED, unfortunately, is the recipient of all the holes in the safety net, and they should be there really for crisis and life-saving intervention. So the hope is that we're matching clients to programs and services that best meet their needs, so we can free up the ER for things like a global pandemic and when we really need that emergency clinical care. So I think that advocacy piece and working on the system is also such a valuable part here. So I really appreciate you highlighting that, Enrique. So I know we have 3 minutes left. We have to unfortunately wrap up this really wonderful conversation. I just really want to thank you both so much, Dr. Nguyendanos and Dr. Munson, for sharing your expertise and helping us really work on this bridge. Really excited for our next few webinars to continue this conversation. I'm just going to bring my slides back up really quickly.
While you're doing that, Courtney, just
Yes.
thank you to the council for highlighting this and allowing us the opportunity to bring attention to the topic.
Oh, thank you for sharing your expertise and joining us in this conversation. It means so much to our community, and thank you for being a champion for FQHCs and HCH programs too. We so appreciate that. Just want to highlight that next week we're continuing the conversation, really squarely focusing on harm reduction. We're joined with experts from Philadelphia area, and then March 30th, really focusing on discharge planning and engaging with medical respite programs, as we've mentioned. And then just want to give a quick shout out to our conference that's coming up in a few months. It's actually going to be in person. It's really happening. So we hope that you join us. And then lastly, thank you. We're going to just put our survey. The survey will happen automatically when we close out the session. So thank you all for joining. Thank you for your questions and all the resources, the wealth of knowledge that you also put in the chat. It's been a pleasure. Thank you all. Have a wonderful rest of your afternoon.